Afternoon. Title of my paper, Comparing Peripapillary Retinal Nerve Fiber Layer Thickness and Visual Field Changes in Primary Open-Angle Glaucoma and Normal Eyes. Glaucoma serves the second leading cause of blindness in the world. Significant loss of ganglion cell occur before identifiable cupping and visual field defects. RNFL loss precedes measurable optic nerve head and visual field damage. OCT is a non-invasive method of determining RNFL thickness and focal defects. Thus, OCT RNFL thickness helps in early detection of glaucoma. Aim of my study, comparing peripapillary retinal nerve fiber layer thickness and visual field changes in primary open-angle glaucoma and normal eyes. This was a study done in patients attending ophthalmology OPD at Government TD Medical College, Alappuzha. Study period is 1.5 years following approval. In POG patients are included patients diagnosed with POG with age less than 70 years, open angles, refractive errors with myopia less than -5 diopter, hypermetropia less than +3.5 diopter, and astigmatism less than 2 diopter. In normal subjects, patients with refractive error less than 4 diopter with no history of glaucoma, IOP less than 21, no visual field defects, normal fellow eye of patients with cataracts, and attendance of patients who have no evidence of glaucoma or family history of glaucoma. Then sample size was calculated from the parent study as 20 per each group. Data collection procedure. After detailed history and preliminary examination, peripapillary RNFL thickness measured from OCT of both normal and POEG patients. All subjects had undergone visual field testing with Humphrey Field Analyzer, and they are classified into subgroups of glaucoma by Hodap's classification. RNFL parameters for these glaucoma subgroups and normal subjects were compared. Then independent t-test, f-test and chi-square test was done. P-value less than 0.05 was considered to be statistically significant. Statistical analysis were performed using a statistical software package SPSS 20. Results: 40 eyes, 20 normal and 20 glaucomatous eyes were studied. The mean age of glaucomatous eyes was 55.9 plus or minus 10.7 and normal was 39.8 plus or minus 9.7. RNFL thickness was greater in superior and inferior quadrant than nasal and temporal in normal eyes. On comparing the average RNFL thickness, it is found to be high in normal control, that is 98.8. In glaucomatous field loss, that is found to be decreased, that is 74.2. On comparing superior RNFL thickness, it is found to be high in normal control, that is 122.2. In glaucomatous subjects, it is found to be 92.1. On comparing the inferior RNFL thickness, it is also found to be high in normal control, that is 131. In glaucomatous field loss patient, it is found to be 91.5. A similar trend was also observed on comparing nasal and temporal RNFL thickness. The average RNFL thickness was also found to be high in early glaucomatous field loss patient than moderate glaucomatous field loss patient and than severe glaucomatous field loss patient. A similar trend was also observed on comparing superior and inferior RNFL thickness. Discussion. This study compared OCT RNFL thickness with visual field changes in POEG and normal eyes. That is, here association between functional and structural findings was compared. Peripapillary nerve fiber layer thickness shows significant reduction in glaucomatous eyes in average value and quadrant-wise values. In our study, those having early glaucomatous field changes by Hodap's classification even shows thinning of average and quadrant-wise peripapillary retinal nerve fiber layer. Thinning of RNFL was more for eyes with severe glaucomatous field loss, which is more than moderate field loss and which is more than early glaucomatous field loss. Conclusion. OCT peripapillary RNFL thickness measurement serve as an accurate and sensitive diagnostic modality for detection of POEG. It is effective in predicting RNFL thinning than visual field changes. By direct investigation of peripapillary RNFL, early diagnosis and detection of glaucomatous progression become possible. And this was my references. Thank you.
Thank you. Why did you exclude those refractive errors?
Because with high refractive error, it can in visual field detection, it can have some negative association.
In the visual fields?
Yeah.
Okay.
And also with high myopia, it can have some effect on RNFL, peripapillary RNFL.
Okay. Isn't this a known fact already before you did the study?
Yes, it was found out in many studies, but now also visual field is being more considered than OCT RNFL in detecting glaucoma. Studies are going on.
Okay.